Hello, 2026 has been a heck of a year for accelerating myopia management options. This year, we've introduced the very latest performance-enhancing Stellus 2 and MyoSmart IQ spectacle lenses. The evidence to confidently treat children at risk before they become short-sighted is really gaining traction, and 0.01% atropine is now available to prescribing medical optometrists such as Aaron's. And this has all been within the last 4 months. So here is my third update for 2026. First, I would like to run through our clinical history on myopia management because experience is really valuable and we do have a lot of it. We embrace innovation, we don't simply follow the mainstream. So the first thing on the block back in 1996 was orthokeratology. Now back then it wasn't marketed for myopia control. Most of us noted an effect, but there was no peer-reviewed evidence. But we were a founder member of the British Orthokeratology Society, so our experience in the use of these complex lenses is extensive. Then in 2015, the decades of myopia research culminated in irrefutable evidence on strategies to slow myopia progression. With the peer-reviewed evidence in, we commenced myopia control immediately. But of course, while the evidence was indisputable, obviously there was no licensed product yet to fulfill the goals. Fortunately, we had multifocal contact lenses, the sort of lenses someone of 55 or 60 might wear to help them read. And just like orthokeratology, they weren't designed for myopia control, but they happened to fulfill the needs. So apart from rebooting Ortho-K as a myopia control option, we also prescribed a specific multifocal contact lens off-label, as it were. And it was not until 2018, 3 years after we commenced myopia control, MySight contact lenses specifically designed to control short-sightedness were introduced. Then in 2021, Hoya introduced their MyoSmart spectacle lens to Britain. We had been anticipating this lens for some years. Clinicians had to be accredited with 100% to prescribe it, and I'm proud to say within a week of its arrival in the UK, we were prescribing this game-changing lens. Game-changing because all prior options involve contact lenses, which carry some clinical and lifestyle constraints. Then in 2025, we were also able to add the equally effective Essilor Stellus spectacle lens to our portfolio. And in 2026, reflecting the ongoing research, Essilor have given us their improved Stellus 2, and Hoya their MyoSmart IQ. And as of June 2026, the licensed drug atropine is now available, but only to ophthalmologists and prescribing medical optometrists such as Aaron's. Now I'm going to expand on those last 4 later, but first I should explain why some people actually become short-sighted. Well, we're actually all born slightly long-sighted because our eyes are a little bit short or a little bit small. So as we grow, our eyes grow in length and we become less long-sighted, which is expected. Ideally, when we've stopped growing, images from a distant object would be focused onto the retina, giving a clear image. People destined to become short-sighted start off long-sighted as well, but for reasons we are now understanding, the eyes don't stop. They grow past the neutral point and keep going. As the short-sightedness progresses, we effectively have to play catch-up with stronger lenses. But ultimately, once the person stops growing at say 18, 19 or 20, the eyes stop elongating and then the patient enters a stable period. The goal of myopia control is to slow progression during this growth phase. Importantly, we can now identify growth patterns predicting myopia onset, and it is suggested we should treat at-risk children before they become short-sighted. The International Myopia Institute states preventing myopia is an even more valuable target for science and practice than reducing progression after onset. So if we know a child is at risk, perhaps both parents are myopic, and we have noted a rapid drop in long-sightedness, should we offer myopia control even though the child is clearly not short-sighted yet? Essilor have even prepared a table with risk levels with this debate in mind. Now, this is definitely not a decision for a clinician to dictate. Trust is essential and time must be allocated to explain parents' concerns. Then a joint decision to treat pre-myopes may be agreed. So what drives short sight? Well, we're now talking about an image shell. Now this eye is not short-sighted, as you can see. Light coming from a distant object is focused through the optical system perfectly on the retina. What's important is the entire image shell is contoured to the retina. So all of the retina is in focus all of the time. Therefore, this eye is not destined to become short-sighted. Now this eye is going to become short-sighted. It's not short-sighted yet. Distance imaging is still focused perfectly at the retina. But the image shell in the periphery is not contoured very well. So while the central vision is focused and the patient will not complain of any problems, the peripheral vision is blurred. Now you don't notice this because it's used for navigational vision and it doesn't have to be a high quality. But the peripheral blur drives growth. The eye decides it wants to grow towards the image shell to make it clearer, which drives it towards short-sightedness. And this is what happens. The eye grows in length to try to correct the peripheral blur, but of course it then makes the eye short-sighted and we have to correct it, which incidentally reconstitutes the peripheral blur. So the treatment aim is to draw the peripheral blurred image shell in towards the retina to ensure all-round retinal clarity, like that, which stops growth factors kicking in because the entire retina is in focus. Since ocular elongation is the cause of short sight, the only true measure of myopia progression is recording eye length. Recording an apparent change in spectacle prescription via a sight test is not adequate, as it is very easy, unless extremely careful, to over-minus young people as they tend to focus their eyes, giving a false reading. The gold standard for monitoring myopia progression is biometry, which records extremely accurately the axial length of the eye. This is an essential piece of kit for clinicians involved in myopia management. We also use retinoscopy, and especially a technique called dynamic retinoscopy, as part of our myopia management. The link below gives more information if you're interested. There's now a significant number of products available to slow myopia progression, some extremely effective, some less so. There are also variations in costs, with predictably the less expensive options being the least effective. This can be very confusing, especially if you're rushed to a decision by busy clinicians. Out of courtesy, all options and their pros and cons must be explained to your satisfaction. This takes time, but is critical, and I hope this recording helps this important process. The final decision must always be a joint one. So I would like to introduce the website My Kids Vision, which is an excellent resource for parents. This bar graph shows the choice and effectiveness of virtually all the options available for controlling myopia. So let's dissect it. And since research is progressing rapidly, let's actually update it. Starting at the very bottom, single vision contact lenses specs are totally ineffective at controlling myopia. At the top would be our holy grail of 100% cessation of myopia progression. And as of 2026, the researchers are approaching this goal. All the premium products are reported as evenly matched for effectiveness and demonstrate at least a 50% reduction. Orthokeratology, MySight contact lenses, and both Stellest and MyoSmart spectacle lenses are definitely our recommended optical products. Next best options are multifocal contact lenses and executive bifocals. And finally, the least effective, with only 28% reduction in progression, is MyoCare and MyoLess spectacle lenses and a 0.01% atropine. Understanding how a blurred peripheral image shell drives short sight explains why all the premium products draw the entire image shell in around the clock, treating the entire peripheral retina. Clearly, the bifocal and MyoLess lens, which is simply a complex varifocal, have limited treatment zones and don't. But as of mid-2026, the 50% mark has well and truly been crushed. Stellus 2 and MyoSmart IQ are achieving 80 and 90% reduction in myopia. In fact, the MyoSmart IQ has been reported to achieve zero progression, at least over the trial period. The ethical conundrum with the poorer performing products is they are not as good at achieving the very thing we are trying to sort. Should we even offer them? Well, I think yes, and we do use the Zeiss lens now, simply because they are less expensive and are certainly better than nothing. So to reiterate, courtesy demands we explain pros and cons and agree a plan with you. How to stop eye growth is a sole goal in stopping progression, but there are genetic and environmental factors implicated. So firstly, let's consider environmental modifiable factors. Like eating a healthy diet, there are no downsides to considering this. These strategies carry zero cost and undoubtedly confer health and fitness benefits. Think of the 30-30 out rule. Never hold reading or any close work closer than 30 centimeters for sustained periods. Have short breaks from sustained close work every 30 minutes. Admittedly, easier said than done, but try your best. And spend lunch breaks outside. I'm led to believe children may spend lunch times looking at phones rather than playing outside. The research actually suggests 2 hours a day outside decreases the incidence of myopia in pre-myopes. The primary non-modifiable factor is genetics. Is myopia present in the family? This is now becoming modifiable actually with myopia control interventions. However, while the highest performing products are getting extremely close to the holy grail of zero progression, we still should not guarantee this result. Understandably, all research results claim on average expectations. This is important as some people will get better results, but others poorer. It means on average, this is what we would expect you to achieve. We must set realistic goals. Actually, those rare poor responses are where adjunct therapy with atropine would be recommended. More later. So some people may still think, look, if you can't stop it completely, why bother? Well, there are enormous reasons for bothering. There are benefits to every myopic patient. Short-sighted eyes are more prone to a range of retinal diseases, and for every unit of myopia we can reduce, the risk to a person developing these problems is reduced by 40%. And that doesn't just mean if we maintain 5 rather than 6. It also applies if a patient is -1 rather than -2. So at every level there is risk, and by reducing your myopia, we are reducing your risk. But also there are societal benefits. As more and more people become myopic, which they are doing, the long-term impact of these sorts of problems on the health service are enormous, and the costs are going to be huge for future generations. We need to try to slow progression as much as we can. This does emphasize the importance of using the most effective techniques for slowing progression. Over the years of eye growth, a less effective treatment will leave more residual myopia. So finally, anyway, let's look at the actual products licensed for myopia control. The first product specifically designed to slow progression was the MySight Daily Contact Lens. The way this works is a central part of the lens is pure distance, bringing everything to a nice focus at the back of the eye where you want it. The periphery of the lens has a different power profile and draws the peripheral retinal image in to contour to the retina, slowing progression. I have to say, contact lenses make an awful lot of sense because they sit on your eye and move with your eye. So you get the full effect no matter where you look. With standard spectacle lenses, of course, if you look off axis, you're getting a different focus profile on the retina. This is why contact lenses were the first to come out. They make a lot of sense and they really do work. This is also a daily lens, which is important as they carry the least risk of infection for young people. They are an ideal lens. So, time now to introduce the concept of effect dose, which is really important. The effect dose is the term applied to the effective time on the eye, and the longer the time, the better the effect. So for any intervention, contact lens or specs, to achieve the maximal effect for myopia control, they must be the primary visual correction. If someone only wants to wear them on weekends, then you can't really offer them because they won't be worn long enough to have a maximal effect. And of course, this raises certain ethical issues. Do you really want your child to wear contact lenses all day, every day? Parents may want them to take them out on weekends or remove them when they first come in from school. So there are certain concepts here that need to be considered, and the parents must be heavily incorporated in the decisions. This dilemma was solved with the array of SPECT lenses, starting with the first Myosmart in February 2021. Now we have the Stellus lens and the significant 2026 performance upgrades of both products. We also use the Zeiss Myocare lens, which is not as effective, but certainly less expensive. So how do they work? Well, proprietary design variations aside, they all have circumferential treatment zones consisting of tiny lenslets surrounding the central portion with full distance prescription. The lenslet distribution ensures a 50-50 split between lenslets and the child's normal vision. It is not all blur out there, so it's extremely clever stuff. The Myosmart and Stellus lenses are classified medical interventions and must be prescribed by an accredited optometrist. Frame fitting and lens centration are critical and need to be dispensed precisely by a qualified dispensing optician to ensure maximal effect dose. While ongoing adjustments are important for all our patients, they are critical to the effect dose of these lenses. Ongoing adjustments anytime is an essential part of our service to you. And finally, atropine. The STAR study compared 0.01 and 0.03% atropine for effectiveness in slowing myopia progression and actually found no statistical difference in performance. Based on this evidence, in June 2026, Santen received approval for the licensed eye drop Ryjunia, which is atropine, for slowing the progression of myopia in pediatric patients. Now, as a standalone treatment, 0.01% atropine shows a modest 28% reduction in myopia progression, so it is unlikely to be prescribed in isolation. However, as a combination therapy, it has significant potential, especially when rapid progression is noted. So if the first line managements, whether orthokeratology, contact lenses or spectacles, are suboptimal, the addition of 0.01% atropine will refine the outcomes. Now, Ryjunia is not available on the NHS yet, but NICE is appraising efficacy, so NHS funding may change in the future. Currently, only medical optometrists, such as Aaron's, can prescribe Ryjunia, and it will be privately. Post-2021, our options to treat expanded. Previously, there may have been reservations about prescribing contact lenses to very young children. We would advise and perhaps decide to monitor very closely. But of course, as we monitor, it is progressing. So the spectacles and atropine allow us to get stuck in as soon as or even before myopia is detected. The range of optical and medical options now available allow us to maximize effect dose without disrupting lifestyle. So if your child would like contact lenses, we can do it. If your child knows they look cool in glasses, we can do it. If, for sport or leisure, your child wants to mix glasses and contacts, we can do it. If your child would benefit from all-day clear vision unaided, we have orthokeratology. And if the optical managements don't give the maximum effect, we can add atropine. So for all ages, we should strive to fulfill individual lifestyle needs. The broad range of options now available allow us to do just that while maximizing effect dose, which is as it should be. So there you have it, the third Myopia Control version for 2026. If any of the stuff is of interest to you, please make an appointment and we will be happy to discuss it. Thanks very much.